Good morning. I'm Drs Essack and I am a researcher at the Centre for Community-Based Research. I work with Hilton on many of these projects, and we have other colleagues who aren't with us today. But if you were there yesterday, you got a slice of what some of the qualitative work looks like, and today we are giving an overview of what the work we do looks like. So we are based in a specific community in KwaZulu-Natal, South Africa. It's semi-rural, high HIV prevalence, high unemployment, and so that's just to set the context for some of the work we do, particularly health research, but we're also trying to focus increasingly more broadly on other aspects of health and wellness. Ultimately, the work we do, we wanted to make a change in the lives of these communities. So the way we frame our thinking is to impact the community directly, or to make broader policy changes that can impact the country more broadly. And I'll talk to some of the work we're doing where we've been able to make community level impacts and where we've been able to make broader impacts at a more regional or national level, and sometimes even out of South Africa. So the mission, just to remind you of our centre, is to improve health and well-being of the Sweetwaters community and the public more broadly. And we do this in different ways, but mainly through intervention trials. So that's all our implementation science research, creating evidence, developing novel approaches, and using methods that combine both the social and the biomedical. So I'll talk through some of the social science and behavioral work we do and some of the clinical work we do. And then lastly, we want to develop capacity building that focuses on community-based approaches. Some of the work that we do, we have data collectors who come from that community, we train them and support them. Others have gone on to be the heads of advocacy organizations like the Treatment Action Campaign. So that is one of our goals, is to develop the capacity of people in that community and enhance that. So this is a picture of our site and what it looks like. It's in an old bus depot, and we've been there now for 20 years. Working with the Sweetwaters community and the broader Edendale and Vulindlela area. In terms of our successes, we completed 35 studies so far. We've screened over 12,000 people, and we're very excited about our very high retention rate in a clinical trial space. We often have more than 90% of participants who are retained at the end of a study. In our current capacity, we have about 15 ongoing studies, different sizes, different funders. So range looking at some clinical trials of STIs to implementation science projects on TB and HIV prevention, to smaller studies on democracy. So our ability is really to do both community, and when we say community, we often go to the people, we meet them in their homes. So we do household level research, or we have mobile vans, or we have clinic-based research where people come to our site and we do our research with them in those spaces. So at the centre, we have multiple focus areas, and just to contextualize the space for you, the centre is one space within the Human Sciences Research Council. There's multiple units. We are housed in the Public Health Societies and Belonging Unit, and I think that's one of about eight units across the HSRC. Our focus has been more applied work in what we do. So looking at theories to some extent, but how we can adapt them and apply them. And we've done lots of implementation science work. So once a product is proven to be effective, we try to find what will make people take them. So some of the behavioral aspects or delivery. So we do a lot of decentralized service delivery work, taking HIV prevention and treatment to people in the communities to see if it improves uptake, persistence or adherence over time. We are proud of the many community interventions we have had over time, and some of these have, as I said, filtered into scalable policy that is in KZN and sometimes applied more broadly. We more recently got our own clinic at the site, and it's not servicing people as in a public clinic, but a clinic that runs clinical trials. So here we are able to test new products, also to do TB studies that, like our proof study, we've done work that looks at gonorrhea vaccines and HIV treatment within that clinic setting. We have a behavior change and digital health, and Hilton leads our behavior change unit. So that's just trying to integrate all the theoretical work and the behavioral decision making that we do across our studies into a more coherent theme, and Hilton will talk about that. And then because we are based in the community, we have community programs. We have a team that is led by Tulani Ngubane, who does initiatives in the community. So alongside us developing their capacity to do research, we are often doing CV writing skills or computer training or career development for that space in the community. We are called the Sweetwaters community. I'm not sure where that name came from. I particularly don't think the water is very sweet, but it's a beautiful, beautiful space, very rolling, beautiful hills, as you might have seen from that snippet in the first picture. It's a peri-urban, semi-rural community. It's not far off from our capital of KZN, Pietermaritzburg, and it's fairly close to an urban center. But if you had to take a drive down there, you would see goats, you would see horses and cows, and so it's just people who are doing their farming and vegetable planting and all that sorts of things. So that's really what the community looks like. As I said earlier, we have a high HIV prevalence rate in that community. We as KZN were the hub or the highest burden province in South Africa, which was one of the highest burden, therefore, in the world. We have lots of early pregnancies and a high burden of STIs, particularly among young women. There's an increasing mental health burden, and we're only now beginning to see some of that unfold through some of our work. So we are welcoming interventions that look at mental health and support mental health in this community. You know that South Africa has one of the highest rates of gender-based violence worldwide. We recently, as the HSRC, not Centre, did the first national GBV prevalence survey. So that is also an area of focus for us, and that was what I spoke about yesterday in terms of the walking school bus. And although we aren't a very urban center, there is definitely an increasing use of technology, and we want to think of how to leverage that better in terms of using cell phones, social media, etc., as intervention across different areas of need. And then to understand complex behavioral and decisional pathways, which I think Hilton will talk to you about under the behavior change component.
Intimate. So morning, everyone. I'm Hilton. So by way of introduction, I'm a senior researcher at the center. And like Zainab said, I look after the behavioral sciences and then sort of behavior change as a focus. And also largely my work is focused on adolescent health and adolescent well-being. So this is some of the stats around, Zainab mentioned the burden that our population faces in terms of, in particular, HIV. TB also a major problem, and other sort of STIs just sort of persistently high across time. This is some data from studies we've done locally. So this is, either big national surveys that are done by the HSRC more broadly across South Africa, or sort of right in our community, locally relevant data. So I'll just point that out as I go through. So in KZN, so the province we're the epicenter of the world's HIV epidemic, and we have a prevalence of around 38.4% for women aged 25 to 49 years old. We have seen it stabilizes over time as people have lived longer with access to treatment. We don't know what's going to happen now with USAID being cut and the Trump administration and how that's going to impact us in the long term. But we have seen a sort of steady decline in the incidence. Prevalence remains sort of stable, and we would expect that as people live longer. Like I said, as in the last 10 years, we've seen, very happily a decrease in HIV incidence. Steady declining, not anywhere near where we should be. But in 2022, this was a large survey done across South Africa. We still had 227,000 new infections amongst women and men aged 15 to 24, just in South Africa itself. So, we still have a long way to go. The STI, this is data from our community. So this was a cross-sectional study that was done right in Sweetwaters. What we can see, I've sort of split it. We've got the 14. This was a group of, we done 14 to 19-year-olds, and we did 25 to 29-year-olds. So you can see the prevalence of each of those age groups next to the STI. But, any STI around 42.5% in the 14 to 19-year-old age group, and 16.4% any STI in the 25 to 29-year-old. What we've also seen is that when we've done longitudinal sort of cohort studies looking at STIs, it remains persistently high. So people you don't have a resolution of the STI, they get treatment. Treatment is very difficult to get. Women also don't want to refer their partners for STIs because women often take the blame for having STIs because, men are, pure and virginal. They don't bring anything into the relationship except goodness. So it's a real problem. So we give treatment. There's been lots of studies that have looked at like partner referrals or giving the female partner the treatment and asking her partner to take it. It doesn't seem to work. And in another study that we did, a longitudinal study that was done in the area, similar sort of STI rates to what you see there, and persistently high. So at 6 months, it was still around that. At 9 months, it was still around that. So very little resolution of STIs. Mental health is obviously a really key problem in South Africa. We don't have a lot of, very strong data. It's starting to build. But obviously mental health has not been a strong focus of most research institutes until more recently. We did a small study, again, sort of cross-sectional, looking at depression or depressive symptoms in young women, and we had a sort of 15.7% prevalence of depressive symptoms in adolescent girls aged 15 to 19. Again, persistently high. It sort of didn't resolve, and it's not unexpected. We have high poverty, we have high gender-based violence, so we would expect there to be, lots of concerns. But again, we haven't looked at, post-traumatic stress disorders and what those might be. We haven't looked at those things, and we haven't looked at more serious mental health disorders either. In terms of behavioral drivers, obviously we sit in we have a melting pot of all sorts of things that affect the pathways of risk. Generally, young people in our communities have a low risk perception. They think, like any adolescent, nothing's going to happen. It'll be fine. We don't have to use condoms. My partner, I love him and I trust him and nothing's going to happen. And we're like, okay, we really wish you would rethink that. But, trust is a fundamental, foundational part of the relationship, so we can't blame them. We have high intimate partner violence. You'll see there's a statistic from the National South African Police Service that, a woman is raped in South Africa once every 20 minutes. So we have, extremely high rates and that sexual violence happens within families. It can be done by your father or your uncle. It's not even necessarily done by strangers. And Zainab yesterday, if you were at the talk, spoke about that walking school bus intervention, and part of that was trying to get girls to schools and creating safe spaces for young women. Men are also face intimate partner violence and rape, but obviously very underreported, and they don't, men don't want to talk about it, and it's very difficult to get men to talk about them experiencing rape. High poverty and very traditional values. So, in terms of adolescents accessing sexual and reproductive health services, they just often can't because their parents will, if you get found out, or the potential consequences and the perceived potential consequences of using a service can be quite dire. And so before they even enact going to a service or even think about going to do it, they stop themselves in their tracks and like, the cost is not worth the benefits of this. So we face many problems. And so, going from that, obviously then community health and well-being is an important focus for us at the centre, and we want to ensure health and well-being by, enhancing access. So how do we make things accessible? By safeguarding rights, but not, access is one part of the problem. You can make something available, it doesn't mean people will use it. So it's also thinking about how do we create sustainable interventions that work for people? How do we make more nuanced, more targeted interventions that people will use and that are relevant for them? So, we're trying to innovate, trying to think about how do we do things better to suit the population's needs and not just create something that researchers want to figure out for, whatever reason they want to figure it out. I was going to say ego, but I don't know if it's appropriate. So we have sort of different areas. In particular, I'm focused a bit more on HIV, but I'm going to take you through some of it, and then I'll swap over to Zainab, and she'll talk about sexual and reproductive health, and then I'll come back for behavior. We thought we would split it up so you wouldn't get tired of us. We don't know how you feel about the South African accent, and I think it's okay. We're English, so I think it's a bit better than if we were Afrikaans. It might be a bit harder for you guys. But so in getting people to test for HIV, the site was one of the first sites in the world to do a very large study called Project Accept. And that was actually decentralized HIV testing through community mobile facilities. It was done almost, I think, how long? 20 years ago.
Yeah, and about 20,000 people.
Yeah, and 20,000 people. And that at that point, decentralized servicing was, very innovative. Now, obviously, there's a lot more of it happening. But, it was a pioneer project at that time. So we do look at different ways of getting people to test. We have family-based models, so going into people's homes and testing. Often it allows you to have a conversation. Lots of children have HIV from birth, but are not disclosed. That's not disclosed to them by their parents. So you have to sort of facilitate that conversation. We have couples-based models, which work with varying degrees of success. Couples, there's lots of sort of issues that come up with couples, and you end up doing a lot of unintentional therapy with couples rather than just talking to them about HIV. But it's a very sort of, once you can get that model working, it works really well. And we've done it several times with a lot of success. And then community-based models as well. And I think that is that sort of decentralization of services. So how do we provide it through, caravans? We take caravans out into the community, park them out there. We've had little boxes in communities where people can go and put a code in and they can get their treatment out of a box so they don't have to talk to anybody. So we're looking at all those sort of, new ways of providing services to people, so increasing access. And then also looking at opportunities for digital technologies and improving HIV testing and enacting behavior. So rapid diagnostics that come with, an app, so someone can download an app and then facilitate their own self-testing through the app. Obviously, when people think about coming to South Africa, they'll often be like, oh, but, will communities be able to use this? Because, is there enough sort of technology penetration for that to be a workable solution? We have found that cell phone ownership is very high. Smartphone cell phone ownership is very high. Lots of times cell phones are shared, so that can create problems with privacy, and you have to think about privacy and confidentiality. But especially amongst the younger generation, the millennials are over now. It's like the next Gen Z or whatever it is. I can't remember. There's hundreds of them, but they are wanting this technology. They don't want to spend hours at a clinic. They want to be able to access it very easily and quickly. And thinking about even information, people get, micro learning and micro scrolling and all of these things, sound bites of information rather than long laborious reading. People don't want to sit there and have to read, how I do this. It needs to be a little Instagram reel for you to want to pay attention. So this is an example of one of our current studies that we're doing. And this is its innovation is in providing rapid diagnostics with an app that people can then facilitate their self-testing of both HIV, pregnancy, and blood sugar levels. We did phase 1 just to look at acceptability, feasibility of doing this. And now we have gone into a larger randomized control trial where we're going to have about 1,300 people enrolled in the study. And we're looking at if the self-testing is facilitated where you can access a community healthcare worker to help you, or if you do it completely alone, or if you just do it in the traditional way where someone comes and does the test for you and see whether or not, what is the acceptability, what is the uptake like. So this is the -1 study was for feasibility and acceptability, usability, all of sort of investigating those issues, the human-centered design elements of the intervention. And then -2, which is the randomized control trial, is currently enrolling at the moment, and we expect to be finished early next year. Oh, sorry. All right, so linking people to HIV care is obviously an integral part of the HIV prevention journey as well. We have done a lot of work trying to understand how do we get people to not only initiate treatment, but then stay in it. Obviously, when we think of treatment, HIV treatment, and any treatment, in fact, as a sort of journey. And so people you have to get them in, you have to get them onto treatment, and then you have to help them through the highs and lows of taking treatment for a long time. It's particularly difficult now that we're seeing people live much longer and having to take treatment right. We have geriatric HIV populations now who've been taking treatment for 20 odd years. And so you've got to think, how do we keep people, especially when they feel better? Often people feel better and then they just stop taking treatment. So how do we support them at all these sorts of stages of the treatment journey? A part of that is to do more sort of human-centered design research about understanding the different types of profiles of people that are taking treatment, so that we can, and there's room there sort of for big data, for taking data from our public healthcare system that we have, and then profiling people to say, these are the different sorts of people there are, these are the characteristics that they have, and so how do we target interventions best suited for that person, to that person, and how do we do it in a way that is sustainable and has the highest effectiveness? And so we're looking at how do we optimize that. We're also Zainab mentioned the clinical trials unit, but we're also investigating new ways of treatment. Obviously, if we can do injectable treatments, it would be a much easier way of treating people than expecting them to take pills for a very long time. And South Africa itself has high acceptability of injections because it's the cornerstone of our contraception, public service interventions, and so people have a lot of acceptability around it. They're very used to getting injections. We've also looked at digital interventions again and looking how we can support people. We've done one where couples that have substance abuse disorders in terms of alcohol abuse. We've taken, at least one of the couples has, interestingly, the intention was to enroll one partner who abused alcohol and had the other partner as a sort of champion to help them. And they would get feedback on their drinking habits. So the partner would get feedback. And when we initially started it, I was like, oh my gosh, we're going to have every social harm imaginable. And we didn't. The partners were quite supportive. But what we also found is that the partners both tended to abuse alcohol. So the rate of high alcohol abuse amongst females was almost akin to males in our population. Just men were slightly higher. And lots of sort of binge drinking habits. So people, weekends, we have shebeens and taverns and things there, and they hit them hard. And then there would be no drinking during the week. So lots of binge drinking habits. They did use it. There was a breathalyzer. So you would use a breathalyzer. It would take your BAC reading. It would then be taken. But we've actually shown it was a first stage sort of phase 1 study just to look at whether or not it would work, so we could anticipate problems, and we're going into a larger trial now. But who knows? We would put it in the NIH and then mental health support. Obviously, a key part of people's treatment journey is the mental health aspects of treatment. South Africa has a lot of undiagnosed mental health disorders. because we don't have a very strong mental health public system. And so, looking at how do we support mental health is an area that needs more work and lots of opportunities. And this is just an example of one of the studies that we're doing again. This is Uhambul Wami. Uhambul Wami means my journey. And what we're doing is looking at public health people in the public healthcare system who are taking treatment. And we're looking at their profiles of dropouts versus long-term users versus short-term users, and looking at where in the journey and at what stage in the journey do they fall out, and then trying to understand those people's journeys in order to use interventions that are available in a more targeted way. So we're segmenting the population. We're doing it's a very big study. I can't remember how many people. It's like 30,000 or something, 30,000 people across the whole of KwaZulu-Natal. And we're currently in data collection at the moment, and we've just started to do sort of human-centered design workshops with key stakeholders and sort of big overall profiles of people. So yes, and I'm going to hand over back to Zay now.
Yeah.
There we go.
Okay, so Hilton spoke about linking people to testing and keeping them on treatment. Another one of our important goals as a centre is to improve access to sexual and reproductive health. And we've done this in multiple ways across multiple studies. We have the Do PrEP study, and I'll talk to that in a few minutes, but one of our key goals is to improve both access and uptake to PrEP and sexual and reproductive health services. Hilton spoke about challenges adolescents have with accessing services. We have a good progressive legal system where young people are able to go to get healthcare without parental consent, but we also have a very conservative healthcare workers who may not always be willing to provide those services in a confidential way. So we have barriers both from the participants who are concerned their parents may find out, but also from providers who are not willing for young people to take medication. So we've had to think about how do we take services out of brick and mortar clinics into spaces accessible by most people in our communities. And part of that is being able to understand what drives people to use a service and what makes it acceptable to them. So Hilton's spoken about DASH and using rapid diagnostic tests with apps. And we also have a clinical study at our site looking at a gonorrhea prevention vaccine. So part of our work, and this is not exhaustive, is to really think about how to improve access to HIV prevention and sexual and reproductive health, particularly for young people. The Do PrEP is our flagship project for PrEP. It is do meaning do, the verb, and also meaning delivery optimization of PrEP. And here we want to understand, in South Africa, the current policy is that to get access to PrEP, you must be tested with a rapid diagnostic test by a healthcare provider who then will initiate you on PrEP if you are HIV negative. And we are trying to kind of dismantle that model in some ways and take it into spaces rather than having young people identify their risk and then go seek access at a clinic facility. So this study, it's a randomized controlled trial in the community. And here in our first level, we recruit about 2,500 young people between 16 and 24. And these are young men, young women, sexual and gender minorities. And we offer them, we randomize them to either get a self-test or to get a rapid test. And then we follow them up at their homes, provide them with a PrEP prescription, and we look at who comes back to get PrEP in 3 months. And we found we've done really good with retention, and people really desired PrEP, but they were not able to access it because clinics are far and because of other reasons. We've completed our enrollment this week, so we've got our 2,500, and ultimately we are hoping that the data we have will inform South African policy And if self-testing is effective and safe to initiate PrEP, that we would move to that kind of model rather than having to rely on a rapid test at a clinic. And I think I spoke yesterday about one of the methods we look at adherence, and that was that emoji diaries fits into this big RCT here. Another of our key important segments of our work is finding TB in the community. Hilton spoke about high rates of TB, and it's also linked to the high rates of HIV in our community. So we've also started thinking about TB diagnosis, and we've got this big study. I think it's come to completion now, but it's also using novel point of care screening tests for community based TB screening, and we've looked at trying to increase the number of cases of TB we find in the community. And linked to that, we are also doing a community-based randomized controlled trial of TB prevention therapy. So some people will get it again in the community, others will get it at a clinic, and we look at the end to compare outcomes, whether people use it more if they get it at the community and stay on their course till completion better if they're in the community versus the clinic. And just historically, we found once you take something to people, you eliminate that access barrier. For example, in HIV, you take it to them in the community, it improves uptake, it improves adherence, and ultimately improves viral suppression. So we try to replicate this model for different types of interventions. Hilton and I are very strongly interested in adolescent health and well-being, understanding some of the challenges they face, enhancing their health, making them aware of some of their health concerns that they struggle with, as Hilton pointed out quite clearly earlier. We spoke a lot about how young people helped us to identify that they were worried about gender-based violence and sexual violence through some of our exploratory work. And so understanding that and providing support and interventions has become a key part of the work we've done. We spent COVID-19 years, like many of you in this room, I'm sure, focusing on the impact of COVID-19. And now we want to sort of think of how to use our Center for thinking about climate change. That's something really important and untapped, and we'd like to leverage opportunities on climate change and young people's health and well-being more. And we've also developed just a better understanding and awareness of how young people prefer their delivery of services. So we focus a lot on preference work through the different preference techniques, best worst scaling, and DCEs, etc. I spoke to this yesterday, but I know all of you were not there. So I want to just talk about one of our interventions that developed from our identification of gender-based violence as a big concern for young people. With the World Bank funding, we did an intervention across multiple schools where we got adults to chaperone a group of about 20 children to and from school, ultimately to improve their safety, or at least their sense of feeling safe. We did this project in 2020, just before we had lockdown for COVID. And after we completed the study, we were asked by the community if they could kind of take it on and hold it and implement it on their own. The outcome was that it did help mitigate against bullying, and young people felt that it created a sense of security for them walking to school. Our community currently holds this and they implement it, and then they've added a homework component. So when they walk kids home in the morning, they also provide homework support. So there are now community buses that were not literally made with tires but feet, and that are working quite well in our space. Handing back to Hilton to talk about behavior change.
This is my last change, so we'll be back today and then we'll be done. All right, so this is a topic that's important, very close to my heart, is behavior change, and we've sort of set up more recently, or looking to set up, a behavior change unit where we can sort of understand better behavior change, also develop sort of theoretical depth from a specifically South African led approach, to sort of understand why people do the things they do, and to leverage the power of behavior change to facilitate the outcomes that we want. So this is some of the work that we've done recently and just recently published, and this is sort of part of our our desire to also not only focus on applied research, but to look at theoretical depth as well. We are also keen to take theories that are developed more in the North or in the West and sort of see whether or not they have applicability to our context or whether or not they need to be changed. And how do we also then build young researchers to not only think about, you know, careers as applied researchers, but also making sure that those, you know, the theory comes up with it, and how do we get people to continue to think about and innovate in the theoretical space. So the Behaviour Change Unit is looking at not just methods, but also theories and evidence for behavior change. We want to understand sort of target behaviors. How do we break them down and understand them in their points? How do we know the mechanisms of action that are important for behavior change, as well as what behavioral change techniques we can use to get the best results we want? We are looking to put in a welcome grant in sort of early this year, and trying to get this unit set up. The decision cascade, which we submitted recently and was published, sort of explores how we think people make a decision to engage with a sort of behavior, and why at each stage they may drop out. So that the decision cascade is not the decision is not like, I want to use services, I'm going to go use them, but there's several steps that need to be navigated in order to make that decision, and that people may fall out at each of these steps. And so how do we then re-engage them in a decision process, but also facilitate them moving through the decision cascade in order to enact the behavior? We've also done in the Behaviour Change Unit, we've also started to use using artificial intelligence, so text to image AI technology, to explore what people think about healthcare workers. So this is work that we're still busy with at the moment. We've done some qualitative work, but we also sort of these images, I don't know how clearly you can see them, but we developed some key images. These are not real people, these are AI generated people, and they had specific phenotypes. So we sort of looked at them, if they were wearing a uniform, if they were young or old, male or female, and sort of saw what people would prefer. And so we got people to sort of choose the one that they would want the most. And we had like 127 combinations that they could choose. What we've we've only just got the data, so we haven't looked at it at any in depth, but what we're seeing is that people prefer female healthcare workers, both boys and girls. It was a small sample. It's only I think it's like 100, and we had 130 people enrolled. But there was a slight preference for older women. And then there was also quite like young men were quite liked as well, but overwhelmingly for older women. And the sort of reason for that was like both the perception of knowledge. So they perceive older people as having more knowledge or more skills than young people, and women as being more caring, and women as being more more open to listening to them. What we saw was we should absolutely not use old men who don't wear uniforms. So they absolutely were horrified at the thought of an old man. But I mean, that's also sort of tradition in terms of like older men are the heads of families. And so you don't want to talk about your sexual history with an old man. Uniforms were also really important. Everyone all of the young people sort of tended to prefer someone in a uniform. And again, because a uniform gives a presence of power and knowledge. And so they were like, no, that person's obviously more educated and they know what they're talking about, so they must have a uniform. So it's interesting because those power hierarchies, it gives insight into how power hierarchies can sort of have a benefit, and then a downside as well. So that's work we're looking at. From the qualitative work that we did, we sort of looked about what influences the decision to use sexual and sexual reproductive health services. And what we would hope to see is that young people are thinking about that when they start to think about having sex, they go, okay, well, I'm going to start having sex, and now I need to, a contraception is going to be important. I should have some condoms, or I need to use PrEP if I don't want to use condoms. And that was not what we saw from the qualitative work, at least. It was the cue to act was post-coitus. So it was, we have sex, and then we go, what have we done? I might get pregnant. I might get an STI. So now I need to go to the clinic. And now you have to navigate all these issues. So there was very little, it seemed to have very little forethought in terms of they're not thinking about sex and so taking preventative action. It's post-act. There's also a lot of negative associations with healthcare services. So it's not even necessarily something you have experienced. It's something you've heard from somebody. It's something that you think, you've heard on social media, or you've heard from, one of where you get information from. So when you were what do you think when you think about sexual and reproductive health services? They're I think about judgment. I think about them being horrible. I think of my lack of confidentiality that I'm going to have. And yeah, so there's all these negative associations with sexual and reproductive health services, which may influence the decision. We don't know its temporality link at the moment, but that could stop people right in the tracks right in the beginning. People are this is going to be a bad experience. Will they even continue to pursue going to services? So lots of negative reactions, lots of negative associations. The costs and benefits of using sexual and reproductive health services were also very subjective. So the same set of factors could be present, but have completely different weightings in terms of how people think they're important to service use or not. So for some people, they'll be oh, I'm worried about being seen at the clinic, but they still go to the clinic because they'll be oh, well, I'll just go to one further away. So they make a sort of action plan to get around it. Whereas some people are no, I'm just not. That, even the possibility of me being seen at one that's, 40 kilometers down the road, I just won't go. So the costs and benefits are very subjective, made from the reference point of that person, obviously, who's making that decision, but their power sort of differs depending on the person. And for some people, there may be lots of costs, but they sort of are outweighed by the benefit of knowing your health. And for other people, the benefit of knowing your health is not that important, and it doesn't outweigh the costs. So what we've found is what we often perceive is that health is really important to people, and that people think about their health a lot. And what, health in terms of priorities of young people might not be the top priority. And then also effort. If it's hard to do something, people don't do it. And so, if there's a lot of effort involved in actually using the service, so now you want to go and you're going to have to spend 3 hours in the clinic, people just don't go. So that's some of the work we're doing now. With digital interventions, I've mentioned some of them before, but obviously we can't continue to live in a world that ignores digital interventions and digital health and technology. And so it's, it forms a very important part of the work that we will do going forward. And we're very fortunate to have a local programmer who's sitting in the back of the room who came with us, who's who knows what happens in the background. We go, can we do this? And he says, yes or no. So he either breaks our dreams or fulfills them. And so we're very lucky to have local talent and local expertise to help us with these things. We do a few studies that involve technology or AI. This was just one that we've done now recently. We've just got a bigger grant to continue to actually expand this work. This was user-centered work to look at whether or not people would engage with a multi-agent AI chatbot to provide HIV support as well as mental health support. And the mental health support training was done on a local counseling, a local counseling approach called Enuka counseling for people who have who suffer with depressive symptoms, so depression and anxiety, and it was done by a local group at the Aurum Institute, which is also a research organization based in South Africa. So we trained a chatbot to respond to two key populations, so MSM and transgendered women. And we spoke to them about, can you enact with it? It wasn't done for a therapeutic purpose. It was done for a user purpose to see what you like. So we don't know anything about whether or not they would use it. You know, we don't know if it was therapeutically effective, but we know what they liked and what they didn't like. So it had, what we found here was that it was, I have to like keep on remembering that this thing is here and that I don't have to look there. It had high acceptability, so participants valued that it could be potentially more private, or the perception of privacy at least. That was a double-edged sword, because there's privacy and people are like, oh, I don't have to like engage with someone, and it feels very private and I can do this in a room. But again, concerns about like what happens to the information when it goes into a chatbot, like who has access to, you know, this big black box. So people were, their privacy sort of a double-edged sword. Very happy with its convenience. I can do this wherever I want. I don't have to go anywhere. I can just sit on my couch and I can talk about it. You know, very also sort of temporal to when you need it, right? You don't have to be like, I feel sad today, I'm feeling worried, I feel anxious, but now I'm gonna have to wait till tomorrow for the clinic to open. You can be like, I can access support right now. So that was very, people like that. Anonymity, people felt like it was like they could be whoever they wanted to be. They didn't have to give any personal information, and also felt like the chatbot was less judgmental. And a lot of, we sort of, in this study, we got people to get counseling from both counselors and the bot, and we asked them to do a comparison. And like nonverbal cues are obviously very important. So for people can often perceive a counselor as being judgmental from nonverbal cues. They think like, oh, that person blinked, or they sort of pulled their face a little bit when I said, you know, something, and I feel like they were judging me, whereas that didn't come with the chatbot. Users appreciated that the chatbot was quite human-like, and it had human-like responses, and it was very easy to use. But some of the challenges we had was first latency issues. So if it took a long time, people didn't like that it took a long time to respond. So that was problematic. If there was any sort of repetition in the response, they didn't like that. They were like, oh, it went around in circles. It didn't sort of continue the conversation, wasn't pushing me along. And then also they were concerned about limited rapport building. So the chatbot was sort of like got to it, right? It was like, hello, why are you here? And it was like, I'm feeling a bit anxious. And it was like, okay, it's like solve your problems, right? So they didn't like that it didn't. So those are things we have to think about, is like, how do we build rapport? And probably the biggest issue with some of these challenges is it broke the illusion of sentience by the actual chatbot. So people would say to us like, oh no, it was very good. And then it started repeating itself, and then I remembered I was talking to a chatbot, not a person. So it broke that illusion. So they didn't particularly like that. But overall, acceptability was good. Improvements, we had a little, this current one was on Telegram, and so they were using Telegram, and Telegram is not hugely popular in South Africa. So WhatsApp has a much bigger user base. I actually think we have the highest. And then obviously this is a really important part of our portfolio when we talk about health. So we're looking forward to developing this and using it in more instances. And so I'm going to hand over to Zane. I think there's 3 slides left, so it'll be quick.
So we are embedded in this community context of Sweetwaters, and a lot of what we do is thinking about how we impact this community and how do we make an influence at a policy level that impacts this community and beyond. So I'll spend a few minutes just talking through some of the work we've done. It's not exhaustive. We've been there for 20 years. And I've already mentioned some of this previously. So we, in essence, don't want to just come in and do research in Sweetwaters. We want to do research with the community in Sweetwaters. So we envision the way we work very differently. We have communities as partners in the work we do. We have cabs that represent those communities, and we take seriously the opportunities to mobilize, engage, and talk with the people with whom we work. And so we do have a very strong presence as the HSRC as a partner. And an example of that was during COVID-19, people came to say, could you guys actually give us the vaccine? We don't trust the healthcare system as much, but we would trust if the HSRC were to vaccinate us. And through our CAB and other stakeholder mechanisms, so we've got expert stakeholders who are in the Department of Health, for example, we use that as a mechanism for shared decision making. So when we have an intervention we want to go put out into the community, they help us in thinking about how best to adapt, co-create, amend, and how largely to implement that so it is feasible in that community. Hilton spoke about testing families for HIV. South Africa at one point was very conservative about their testing, and also it was quite a stigmatizing experience. So when we went to families and we said we want to test your adolescents, adolescents are having sex, they were really worried, but negotiated with us the ways in which we could do that made them comfortable, and we learned in the process. People are open to learning things, but we have to manage that in a very careful way. So partnership really becomes integral here. And we have a thorough approach to which we recruit, engage communities. It is not the ideal. So we would want to work towards something where the community really does influence our research agenda. In some ways they do, but in some ways we are addressing their major health concerns that present through statistics. They often say to us, yes, HIV is a problem, but unemployment is even harder. Or yes, HIV is a problem, but I really am worried about when I'm going to get my next meal. So we've also had to acknowledge that what are global priorities for health and well-being may not be community priorities. Load shedding was a big problem. They were like, our lights are off and you are asking us to participate in this questionnaire. So thinking through those things carefully is important. And I think important to us is really taking, where possible, members of that community and building their capacity to be able to do the work themselves, participate by being data collectors or analysts or in some sort of capacity in the research world. And an example I spoke about yesterday was our CAB. We had an adolescent CAB, and one of the chairs of that adolescent CAB is now part of a global CAB. She's written a book, and so lots of things that help just to, and she didn't write the book because we helped her write the book, but just getting that out there. And everyone on our CAB also had done really well in their grade 12 exams. So it is kind of supporting that environment and creating just a space for people to feel seen and heard. And alongside the fact that we can't always address their issues, but know they are important, we have a community programs unit. So this is not funded often, and funders don't want to be providing vegetables to people or things like that. So we have a team that works really hard to ensure that the community gets what it needs, and that some of the work we do has more sustainability long term. The community walking bus is an example of something we evaluated that has been taken up and owned in the space. We also have a clinic that is like almost semi-private, and it was from an idea that we had tested when a retired nurse now heads up this clinic. There's a small fee that you pay to access the clinic, but you minimize the long queues, you get better kind of care. So she's been able to do this in multiple ways. They're across South Africa now, and the community has gotten better care and feel that they access a more quality service in that way. And we've got sewing programs for some young women who participate in prep studies, for example. So we get them to learn how to sew. And school uniforms are a thing in South Africa. We all wear school uniforms, so they often will create a skirt and then go to their schools to sell. So in that way is helping the issue with poverty in the community. And that's the kind of things we think about alongside the research we do to remain embedded and to remain partners with our community, to hear their voices and to, where possible, address some of their concerns. And that is it. Thank you very much for your attention.